Good evening, everyone, and welcome. I'm Longsha Liu, a Stanford medical student and founder of an AI-driven healthcare startup. And it's my pleasure to open Unlocking the Future AI in Asian Health, brought to you by the Stanford Center for Asian Health Research and Education. Tonight, we stand at a pivotal moment. Artificial intelligence is no longer the future of medicine. It's here, reshaping how we detect, treat, and support patients. From breakthroughs in precision oncology to next generation cardiovascular risk models and smarter clinical decision support systems, AI holds immense promise for delivering more equitable, personalized care across diverse Asian populations. We're honored to be joined by three leading experts who have each pioneered novel AI applications in healthcare. Over the next hour, they'll kick off with 10-minute flash talks, sharing the latest advances in their fields before reconvening for a deeper panel discussion, where we'll explore challenges, ethics, and the path forward together. To launch our flash talks, please join me in welcoming Dr. Ruijiang Li, Associate Professor of Radiation Oncology at Stanford. Dr. Li's research focuses on developing AI and machine learning methods for medical imaging and precision oncology. He has led groundbreaking work on predictive modeling in cancer prognosis and treatment response. Please join me in welcoming Dr. Li.
Okay, thank you for that very nice introduction. It's my great pleasure and honor to be here and present a topic on AI, the use of AI for precision oncology. So in the current oncology landscape, there's a major challenge that we face today, which is if you look at across all the cancer treatments across all different tumor types, roughly around only 30% of the treatments are effective, meaning only 30. These treatments are only working for a minority of patients. What this means is that patients will suffer unnecessary toxicity and side effects, which can be serious. And also, at the same time, when these drugs are not working, and this patient will endure financial burden for this ineffective treatment. The problem is there's no way of tell which patient will respond to a certain therapy. And now there's the most effective way right now is these genomic tests that this targeted therapy are effective. However, the problem is only 15% of patients will harbor these targeted mutations, meaning still a vast majority of patients don't have specific tests that can tell which treatment will work for that patient. Now, the hope is that with AI, it can help us to analyze all the clinically available data, including radiology images, digital pathology, and also clinical reports, and to really combine all these sources information and identify the best treatment for each patient. Then the promise is that with AI, hopefully we can expand the number of patients who can benefit from precision oncology. So how do we realize that vision? Right now, one of the most exciting developments in modern AI is called a foundation model. Now, you may not what is a foundation model, but I'm sure many of you have used this tool called ChatGPT. This is a classic example of foundation model. So a foundation model is a large-scale AI model with billions of parameters. This means that these models can have capacity to learn very complex pattern in the data. These models are pre-trained on massive, diverse data sets that are unlabeled, meaning that in medicine, it's hard to get high-quality labeled data sets, but with this pre-training technique, we can use unlabeled data. And these foundation models are highly adaptable. They can be fine-tuned for specific tasks with relatively small data sets. That's also huge beneficial in medicine because we usually don't have large enough data sets for a particular problem. Typically, these models can be made to incorporate multimodal data, such as text, images, audio, video. which were also seen in medical practice. Foundation models can general purpose, meaning they can be applied to a whole range of applications. So there is an annual report that comes from Stanford Institute of Human-Centered AI. It's called AI Index Report. It's been running for the past 8 or 9 years now. Now, in this year's report, they highlighted a few, some of the foundation models in medical domain. And this spans from majority of them are in the domain of radiology and pathology. But also there's one in oncology, which is called MASK, was just published this year. This is the one I'm going to talk briefly about today. So in this MASK model, it is a regional language model that can incorporate both images and text information. So to train this model, we essentially look at all the publicly available articles, over 1 million articles related to pathology, and we extracted 1 billion text tokens. And on the other hand, we collected all publicly available pathology images across over 33 different 33 tumor types. Overall, we got 50 million of these images, and we feed this image and text data to a multimodal transformer. The reason it's called MASK is because it's based on a special training technique called masked data modeling. That's the reason why it's named as MASK, because of the technique we use. So, but then it still has, the model has to learn the relationship between these images and text. So for that, we curated a pair, image text pairs that this text essentially describes what's in that particular image. And we had about 1 million of these image text pairs that can be used to train the model such that it learns the relationship between the pathology images and the texts. So once the model is built, then we can apply this foundation model to a variety of different downstream applications. One of the applications we explored is predicting cancer treatment outcomes. So for that purpose, we used the digital pathology slides. On the other hand, we also have pathology reports. Then from these two modalities, we can extract image and text information and then combine them for outcome prediction purposes. And we explored a variety of applications, including predicting relapse in melanoma, predicting survival across 6 different major cancer types, and also predicting response to immunotherapy. So in one of the applications we look at in non-small cell lung cancer, this foundation model essentially performed quite reasonably well when only image or text information is taken into account. However, the best performance we got is just combining the two modalities that we got over 75% accuracy for predicting response to immunotherapy response. Now, when we compare with the clinical tests currently available in practice, this model has around 20% improvement in terms of accuracy. Because of that better accuracy, the model could identify twice as many patients who would have responded to immunotherapy. And also we got similar results for gastroesophageal cancer. This is also a highly prevalent disease in Asian population. Now, when we look further into high performance across different ethnic groups, racial ethnic groups, we show that in the model seems to perform slightly better in Asian population compared to non-Asians. Now, so that's a quick review of the work we did, but there's still a lot of things that need to be done in the future. One is to really test this in larger populations so that model performs robustly across different racial ethnic groups. And also we're interested in to apply this model to address some of the unmet needs, especially in Asian cancer patients. One of the examples is in Asian non-smokers with lung cancer. These patients typically have EGFR mutations, and they get targeted therapy for their cancer. And the goal is really to predict which patient will likely to have a long-term response to these therapies. And we're lucky to have a seed grant from Stanford Center for Asian Health to support this work. But in addition, there's other high prevalent disease such as liver, stomach cancer in Asian populations that will help also to address with this foundation model approach. That's the end of my talk. Thank you.
Thank you, Dr. Li. I think it's very exciting that the AI models that we see today are only going to be getting better and better as time goes on. And the quick question for follow-up that I wanted to ask you is, in just the last week alone, we've seen a release of from Asia, the QWIN and ERNIE models, right? And models will be continuously released quite rapidly over the next couple of months. And given that rapid pace, what adaptive validation frameworks or continuous auditing processes do you then plan to employ to continuously monitor the performance and to scale the MUST model across beyond just GPT-4 into all the future models coming out?
Yeah, that's an excellent point. I think the key for clinical problem, the key is really to validate in a well-defined population. What that means is what's typically done for a clinical validation is we enroll patients in a prospective trial and follow them for their response to treatment or their survival, and then that typically requires time. In some of the cancer populations, it would probably take a year or even several years. And then we look back and see how the model performs in that clinical trial population. So it does take a lot of efforts and resources to really rigorously validate these models in the clinical setting. And it's hard work, but that has to be done before these tools can be safely deployed in clinical practice.
But definitely very exciting, and thank you for all your work. And thank you, Dr. Li, for that insightful presentation. Next, we're excited to welcome Dr. Pete Zushin, a postdoctoral fellow in the U Lab at Stanford University. Dr. Zushin's work lies at the intersection of biomedical data science and translational cardiology. His research explores how AI can be used to personalize cardiovascular treatments, improve patient risk stratification, and shape the future of precision medicine. Please join me in welcoming Dr. Zushin.
Hi, everyone. I just wanted to thank the Stanford Cares and Nina and Longshai here for inviting Dr. Wu and myself to share some of the different endeavors that we're undertaking in the lab here in order to utilize AI in personalized cardiovascular medicine and how we use it for risk stratification and also for drug design. So cardiovascular disease. So there we go. Cardiovascular disease is a worldwide epidemic at this point, and it is negatively affecting certain areas of the globe compared to others. Here in the US, you can see that there's not a lot of mortality from cardiovascular disease, but moving across the Atlantic, you can see Africa, the Middle East, Asia, South Asia, Southeast Asia, East Asia are all negatively affected with cardiovascular disease and have fairly high mortality rates as a result. So there's a diagnostic and a therapeutic gap in cardiovascular disease, specifically pertaining to Asia. And so the daily loss for cardiovascular disease per 100K individuals, and this is the disease-adjusted life years for these individuals, is disproportionately affecting these regions of the world. And so from cardiovascular disease, you end up with greater death, disability, and then and also any other related diseases that might come along with it. And this results in direct healthcare costs for each of these governments or the individual. And then there's also indirect costs for the lost productivity and taxpayer input from that area there. So there are some unique challenges that are going to be that need to be addressed for these areas of the world, as well as here in the United States as well. And so the human population across the globe is very diverse. Here you can see this is a UMAP of all of the different biobank genomes that are currently available, ranging from the UK to Singapore to South America, everywhere. And so this is kind of the gestalt of how we are seeing differences in human genetic makeup. And so diabetes risk comes into this as it differently for different people, depending on where you are in the world. And so this is from the NIH over in the UK. And so NHS currently recommends diabetes prevention for people with BMIs over 30 for white people, or 27.5 for some ethnic groups. And so that 27.5 is actually a little bit higher than what we would even see or even recommend for people from South Asia. A BMI of 24 is where we identify a risk for diabetes in these individuals. Arab and Chinese are a little bit higher than that at around 27. African and African American a little bit higher, and then white up there. So there's a big difference, and this all comes back to genetics. There's a big difference in how everyone's body handles the risk of diabetes, and diabetes is very important in leading to cardiovascular disease. So HFpEF, heart failure with preserved ejection fraction, is on the rise as a result of the diabetes epidemic that occurs. So a normal heart, when you introduce obesity, either through, and then additional insults through sodium retention or mechanical factors relating to maybe genetics, systemic inflammation as a result of obesity, and then other comorbidities like hypertension and diabetes, you can end up with enlarged left atria, thickening and the stiffening of the left ventricular wall, which results in ejection fraction changes and lower blood circulation as a result. So all of this is important when we biologists are trying to take a therapeutic from bench side, as we say, to the bedside. And so most scientists are familiar with HeLa cells, Henrietta Lacks cells, where we can introduce novel therapeutics into tissue culture here. So we have cells in a dish, and the cells in the dish share 99.9% of the genetics. And so you get some really nice, clean differences here. Whenever we take them into mice, there's a little bit of a greater genetic variability, but even mice share about 98.6% of their genetics with the other one. That's closer than fraternal twins. And so we can see that this drug might not necessarily have as clean of a data set in these inbred lines. But when we take it into humans, right, I think I've already made the point here that humans are extremely genetically diverse. And so what we need, even though we might have 1,000 different cell lines from individuals from around the globe, whenever we look at this drug X, we need to test many people in order to make sure that our drugs are going to actually have an effect. So we use iPSCs, induced pluripotent stem cells, in the Wu lab. And these are taken from individuals who come in through the clinic, have chest pain or some other type of cardiovascular disorder that they don't necessarily know why that occurs. And so we take these white blood cells, we reprogram them, and then we can differentiate these iPSCs into any number of different cell types that we want. So in the Wu lab, we specialize in cardiomyocytes, endothelial cells, fibroblasts, smooth muscle cells, anything that really goes into what makes the heart function. And so here, this is just a kind of a loop, and you can kind of just follow it around clockwise here. So starting with number one, this is how we envision utilizing AI in order to enhance the kind of like the circularity of drug design and the iterative process that it entails. So generation of iPSCs up here at one, generation of iPSCs drive cardiac cells to model different aspects of heart disease. You can model different individuals here from different walks of life, depending on where they're at in where they were born or where they're at currently in the world. We can take those novel insights into different models like mouse models, rat models, things like that. And then from there, we can actually use AI and machine learning in order to identify different patients with mutations that could have therapeutic potentials, but really what we can get out of this is we can potentially determine emerging strategies in order to kind of stratify how someone might respond to a specific drug of interest or to a specific intervention for clinical manifestations of their disease. And so we can predict their susceptibility and hopefully mitigate that with these cells in a dish, and get a good idea what their genetics will have, or how their genetics will play a role in the amelioration of their disease. The other way that we do this in the lab is we design biologics, drugs, different types of peptides through AI/ML. And so these AI-generated therapeutic hits can then be used with a technique called cell village. And so these cell villages are usually made up of 10 to 20 different individual iPSC lines that have been co-cultured together and differentiated towards whatever cell type we want to look at. That could be cardiomyocytes, the endothelial cells that I mentioned earlier. And we can take these different cell villages made up of people of different sexes, races, ages, or different diseases, and we can culture them as organoids, which is what this little round structure here is in the middle. We can do organs on a chip where we have media circulating in the blue right here and then cells in the bottom with the red. And then we can apply different sequencing technologies to these. Attack sequencing, RNA sequencing, usually from a single cell variety because we want to be able to parse out individual cell lines and trace them back to the individual in order to see exactly how these therapeutics that we are testing are having an effect in this specific individual, in that specific cell that we've differentiated them towards. And so what we can get out of this is an in vitro clinical trial-like efficacy and potentially toxicology results. And so we're using iPSCs in order to model how drugs are going to affect individuals later on. So we think of AI as something that can help integrate all of these different genetic, physiological, and lifestyle factors in order to better implement personalized and precision medicine. And so we focus primarily on mechanism discovery, at least that's how it started. And so we look at people's genetics and how that leads to the differential phenotypes and physiology that these cells exhibit. But then we can also take into this and we can maybe model surroundings. We can model your health along with your cells. And then taking all of these then together and putting them into an AI/ML model, we could potentially come up with improved health and clinical outcomes for these individuals. And then lastly, there's some therapeutic development ramifications as well for either biologics or small molecule validation. And this is an iterative process where we come up with a new compound that targets a specific protein of choice, and we take it into cells, we see how it works, and then we modify that biologic in order to maybe act in a more specific manner or less specific, depending on what the goal is. And with that, I'll just I'll thank everyone here who has helped out with these projects, the Chan Zuckerberg Initiative for their funding, NHLBI, and then as well as Stanford Cares and Stanford Medicine for their time here.
This has been very fascinating and a very exciting pipeline, and thank you for sharing that. One question I did want to ask you, Dr. Zushin, is cardiovascular risk factors do vary dramatically across East, South, and Southeast Asian populations, right? So how does your model or how can other models adjust for the region-specific epidemiology, for instance, the genetic differences or dietary lifestyles and cultural influences?
Yeah, so that's a great question. Whenever you take cells in vitro, it's very difficult to model things like that. But with the advent of single cell sequencing technologies, we're able to go through and we can see what the epigenetic changes are in a specific person's cells. And so we can co-culture all of these individuals together and see how an individual therapeutic can affect them on a personalized basis.
Thank you for sharing. And I think I can speak for all of us to say that the future of cardiovascular care is bright thanks to the work that you and your colleagues are doing. Our final speaker this evening is Dr. Jonathan Chen, Assistant Professor of Medicine and Biomedical Informatics at Stanford University. Dr. Chen leads efforts in developing clinical decision support systems and applying machine learning to extract real-world insights for electronic medical records. His work bridges the gap between data science and frontline medical practice, with the goal of delivering more informed and equitable care across diverse populations. Please join me in welcoming Dr. Chen.
Hey everybody, so many dynamic things to talk about. Just think about the very disruptive, changing world we're living in. It's really hard to tell what's real and what's not. So many things sound promising, and so many things you can't tell the difference. So with a side story, just for fun, did you all hear about this story? It was maybe a year and a half ago. A Hong Kong finance worker gets an email from his boss. He says, "Hey, you need to move some funds over to some different accounts." The guy says, "That's a little bit odd." He emails back, saying, "Could we get on a quick Zoom call, a video call? I just want to double check I'm doing the right thing here." He gets on the call, and there's his boss, the CFO. All his coworkers are there too, just nodding along. Says, "Yeah, we just have some different accounts. We just need to move the funds through." Okay, clicks on the button. Transmits $25 million out. The largest cyber scam, first of its kind in history. That was not his boss. Those are not his coworkers. Those are not real people. People just got to sample their images and their voices and just made AI generated avatars to impersonate people. It's really bizarre. You can't tell what's real or not anymore. Human versus computer generated information, real versus fabricated. How do you tell the difference? And what does that mean for the world we're living in? If you operate based on the where we've been, you're going to be left so far behind. Optimistically, think about where we're going and what the potential is for all of our health, including for Asian health. I clearly have some kind of nasty hereditary condition in my family. I have multiple aunts and uncles with pancreatic cancer. Both of my parents have died of cancer already. I'm kind of waiting my turn, but how do you even find a specialist who can give you an answer? These are understudied areas. I think AI is not going to answer every question, but it's going to open up a lot of avenues. This chart shows over time how well different AI language models have done in answering medical questions over time. 5 years ago, 6 years ago, I had students working on this, 35% accuracy. Unusable. Who cares? Then a couple years ago, wait a minute, GPT 3.5, the first version of ChatGPT, could kind of barely pass a medical exam. Yeah, but if you want a doctor who barely passes medical school, you're going to talk to a chatbot? That's not smarter than me, yeah? Right? That's what my colleague said. I thought, boy, is that the wrong way to think about this. A few years ago, this technology was unusable. Now it's barely passing. It's not that hard to project where we're going in the not distant future. And indeed, a matter of months later, GPT-4, MedPalm 2 emerged, can now handily pass this exam. And this chart is out of date. Now there's Gemini, now there's AMI just came out, O1, DeepSeek. They just crushed this benchmark, over 90% accurate, scoring far greater than your average physician would. Although this is what, multiple choice questions. Give me a break. Ain't nobody's job is to answer multiple choice questions all day. We have to deal with complex, open-ended, nuanced reasoning in the realm of medicine. So how is that going to help us? Well, we raced to get this study done a year and a half ago. Our medical educators took the real exam we give Stanford medical students to give a complex case vignette. And it's not multiple choice questions, it's complex, like summarize this case, give a differential diagnosis, explain your reasoning. But critically, we have a way to score this exam. We have a way to give feedback and points to our students on what they're getting right and what they need to keep learning. So we just tried this with GPT 3.5, and out of the box, whoa, that could kind of barely pass even a complex open-ended medical reasoning exam. We were on the brink of publishing this, but you just turn your head for 1 second. Disruptive technology wave. It's like the internet just got invented 2 years ago. Everything's rapidly moving. Redo it. Actually, we had to redo the whole study because GPT-4 comes out, and now it handily passes exam. It's not borderline. These are not subtle changes. And by the way, this is pretty out of date. GPT-4, that's 2-year-old technology. That's ancient technology. Just for context, here's GPT-4 again, score distribution on the right on this complex exam. On the far right would be Stanford medical students. Hey, everybody passes eventually, although it does beg the question, what is the point of this test? What's the point? It's supposed to be to screen our students to see if they can learn and can demonstrate sufficient knowledge to be allowed to see real patients. What's the point? When a publicly available, fully automated chatbot can answer these questions, in fact, it outscores our average student by a couple points. Then again, you're going to hear all sorts of things, including the exciting research we've just heard about. AI can do this, AI can do this. So exciting, so impressive, but also so irrelevant. Because no one's going to let a robot take care of a patient yet. So the really more relevant question is what happens when you give humans access to these tools? Does it actually change their behavior? Does it make them any better? We got a lot of press on this study several months ago. Randomized control trial. Complex case vignettes, diagnostic dilemmas. It's not multiple choice. You need expert consensus grading. What's your differential? Explain your reasoning. What are your next steps? And we randomized half of real doctors reviewing these cases. And he said, you can look up anything you want in the internet because that's how real medicine we practice. You don't expect somebody to know it off the top of their head. And here's how well these doctors do when access to the usual internet, up to date, Google, PubMed. Just don't talk to a chatbot AI system. And they actually do pretty well. A doctor who has access to the internet is really hard to beat on a knowledge exam. We randomized the other half of doctors that have access to a chatbot, ChatGPT-4 in this case, and found that they did a little better. Actually, not that much different, which is weird. This is not what we expected because it turns out if you ask GPT-4 by itself, it actually outscores all of the doctors, including the doctors who have access to GPT-4. Like, what on earth is going on? This really flies in the face of the fundamental theorem of informatics. Human plus computer, when combined, will deliver better results than either would alone. Doesn't that sound so good? I used to say that at the end of my talks all the time for years. I don't say that anymore because I'm kind of not sure right now. And again, these are old results. We've now shown updated ones with reasoning models, O1 and beyond, where this pattern is probably being reinforced even further in terms of what computers and computers plus humans are able to do. Then again, okay, fine. Many of my colleagues made it. Sure, computer's very smart, knows a lot of stuff. Okay, but hey, I have the human touch. You can't simulate the kind of empathy and personal connection that I can offer my patients. So some fun studies emerged in the prior year as well. You might have heard about these. Patients ask medical questions, doctors answer those online, and then they tried having some of these chatbots answer these questions and found that the chatbot generated answers scored higher in quality and in empathy. Like the robots are nicer to people than real human doctors are. And to be fair, I gotta answer 100 messages per day. I gotta be kind of terse and to the point. I don't have time to write some flowery, empathetic response. Obviously, I think there's something very important, special about the direct human-to-human connections and empathy we can make with each other. However, studies like this show us that we as humans don't have as much of a monopoly on empathy and personal connection as we might like to believe. And why I fully expect, for better and for worse, more people are going to receive therapy, counseling, and advice from automated bots than live human beings in the not distant future. Because we as a human-driven workforce can never keep up with the overwhelming demand for such services, especially across cultural and language lines that our classical services just are limited by. I encourage you just to look up and read this two-page essay. It's very brief. It's meant to be very provocative and kind of entertaining to read. But it describes an early encounter I had with one of these chatbot systems. I thought I was going to trick it. I know I've studied these things for years. You can make a chatbot say really dumb, stupid, racist, misogynistic things. Here I give it an ethical dilemma. Patient with worsening Alzheimer's dementia, choking on his own food. The doctor's going to place a permanent feeding tube in. I got to talk to the wife. I switched roles. I said, chatbot, you pretend to be the doctor. I'm going to pretend to be the patient's wife. I want to see how you would have handled this conversation. I'll tell you just the punchline, which is at the end of it, it was a very disconcerting experience because I realized that chatbot was providing better counseling than I did in real life. In real life, I kind of just got tired after half an hour. I said, doctor, tomorrow we'll talk to you. And it made me question some, like, what is the purpose of my existence? But in a naive, techno-optimistic way, I would say there's something very compelling here. By having these human-computer interactions, this virtual conversations, you can practice high-stakes conversations and relate to people in a low-stakes practice environment. And ironically, we could also use these computers to improve the most human skills we need to better improve the healthcare we provide. Some closing quotes. Warner Slack famously ripped off of Arthur C. Clarke. He said, any doctor who could be replaced by a computer should be replaced by a computer. Many people misinterpret this. We're advocating for replacement. No, no, no. This is saying you cannot replace a good person, no matter how good the computer gets, because we provide very different specific value that a computer just doesn't. And by the way, when there are tens of millions in the US alone, billions of people worldwide who have deficient access to medical care, stuck on multi-month waiting lists, or just can't see a professional at all and get expert advice, you should hope, we should dream, we should beg. Please, let's get some AI in here to help reach the patients we need and also manage the overwhelming mountains of paperwork we're saddled with. Many of our colleagues, though, would say, look, AI is not going to replace anybody, all right? But the people who learn how to use it may very well replace those who do not. So I'm very glad to be at a place like Stanford and organizations like here thinking about the current, present, and the future to not just advance the state of the art in terms of technology, we'll do that too, but how do we train and retrain an entire generation like Longshaw right here on how to be a doctor of the future to safely and effectively integrate intelligent systems into our patient care. Thank you, everybody.
This was an incredibly thought-provoking conversation, and thank you, Dr. Chen, for mentioning this. And I couldn't help but think, about Alan Turing's test in 1950, when he really step-sided the murky problem of defining thinking, and instead asked, can machines imitate human responses so well that an interrogator can't reliably tell them apart from a human? And until 2022, I never really thought that we were ever in peril. But now that today's language models can routinely pass the Turing test through advanced linguistic mimicry, Dr. Chen, I have to ask you, what novel evaluation frameworks or benchmarks do you propose that can distinguish mere surface level imitation from genuine reasoning? And how can we recalibrate our trust in AI systems that can so convincingly masquerade as humans, especially when it comes to healthcare?
It's challenging. It's challenging. The world is a disruptive technology. It's like the internet got 2 years ago. This is my full-time job. I cannot keep up with it. Things keep moving. We race to get a study done in GPT 3.5. We turn our head. Your study's obsolete a month later. Like, oh my gosh, right? We're frantically trying to keep up. You reference the Turing test, right? The imitation game. Through a virtual interface, a chat interface, can you tell if it's a human or computer? And at this point, clearly it's getting to the point where it's really hard to tell. You probably can't tell in a lot of cases. So we had to up our benchmarks. Multiple choice complex medical tests, those have been crushed. They've been crushed 2 years ago. Well, okay, open-ended reasoning. Yeah, multiple part questions. We did that in the past year. They're getting saturated now. We need to go to the next level of where are the distinctions. And now it's more like history taking, which also like the recent Google AMI paper is showing that's pretty feasible as well. Other physical interactions and next level judgment. I've been impressed with thinking like, by the way, look, you're in medical school right now, is that right? Like, what are you in school
Yes.
for? Why bother? Why bother? A computer's just going to do everything, right? Is that what you think? Is that what you feel sometimes? I've had students in training ask why I don't know why I'm even in training anymore. You really do matter because you do something different than what a computer does. So how many of these things can a computer do and not do? It's not just knowledge, you need knowledge, but you need judgment of what's credible or not. You kind of need empathy, but I know golden retrievers that are nicer than half the doctors I know. But it's also, do you have empathy? Can you communicate? Can you negotiate a situation and convince somebody to do something? Um, you need to accept liability, but an insurance company accepts liability. That's not much of a reassurance. It's a professional who takes responsibility and will advocate for your situation. This combination of things is what I think what makes a distinctive professional that we need.
Thank you for sharing that. Well, this has been great, and thank you to all our speakers and everyone who joined us this evening. If you'd like to continue learning more about AI and health equity in Asian communities, please visit our website at asianhealth.stanford.edu. And we hope tonight's discussion has inspired you to think critically and compassionately about the intersection of technology and health equity. Have a great night.